This webinar does not offer continuing education credits, and we will be recording this webinar for later viewing for those who are unable to attend. If you have any questions, please save them until the end, and that is when we will enter our Q&A portion. And in the meantime, please feel free to utilize the chat to enter in any questions you have during the presentation. And again, welcome to our webinar, Beyond the Scale, Improving Access for Incretin-Based Therapies. I'm going to go ahead and introduce our three excellent speakers. We have Dr. Kylie Funk, who is an associate professor and clinical faculty member at the University of Minnesota College of Pharmacy. She provides patient care at the University of Minnesota Mill City Clinic, where she primarily manages patients with diabetes and/or weight-related conditions. At the college, she teaches diabetes and weight management content to pharmacy students. She has also developed and delivered many continuing education presentations on these topics for audiences, including physicians, nurses, and pharmacists. And then we have Dr. Abby Lennon, who is a clinical pharmacy specialist at Inova Health. In her role, she provides comprehensive medication management for cardiometabolic conditions under a collaborative practice agreement for patients undergoing bariatric surgery and/or medical management of obesity. She established pharmacy services in the clinic in 2022, and most recently has grown the service by providing follow-up visits for those on incretin medications, which she will discuss further during her portion of the presentation. And then we have Dr. Shannon Finks, who is a professor of clinical pharmacy and translational science at the University of Tennessee College of Pharmacy. She is the president and co-owner alongside her husband, Dr. Lloyd Finks, who is a physician for Zoop Medical Services, a concierge medicine practice in Memphis, Tennessee, where she oversees comprehensive medication management services for her interdisciplinary team. And in this clinic setting, her pharmacist practice under collaborative practice agreements and manage cardiometabolic, pharmacogenomic, and hormonal-based services with an emphasis in cardiometabolic and menopause medicine. Welcome, and I will pass it over to Dr. Funk.
All right, thanks so much for that introduction, and thanks for hosting this webinar. I'm looking forward to presenting now, and so we'll get us started out with when we think about access, one thing that we think about is indications for these particular medications. And so my part of the presentation will be about expanding coverage for GLP1, plus minus GIP agonists, and weight management. And we'll talk about both the current indications and emerging indications. So we can go to the next slide. And I have no disclosures. Next slide. So we'll start off with those current indications for these medications in people with obesity that extend beyond weight management, and talk a little bit about the clinical evidence supporting their use. And then the second learning objective is to evaluate emerging data and potential future indications for these medications used in weight management. So we'll start by those current indications, and I will start with the one that's been around for the longest, which actually isn't too long, and more recent indications as well. And so I want to start off by kind of this high-level overview of the SELECT trial. And so the SELECT trial found reduced cardiovascular events in adults with pre-existing cardiovascular disease and overweight or obesity. And again, high level, they enrolled patients with pre-existing cardiovascular disease and a BMI greater than or equal to 27. And these patients had no diabetes. And when the trial randomized them to semaglutide or placebo, they found that patients on semaglutide had a reduced 3-point MACE, so major adverse cardiovascular events. And the 3 points are a composite of non-fatal MI, non-fatal stroke, and death from cardiovascular causes. So we can go to the next slide. And so really the question here is, now this has been approved, semaglutide has been approved to reduce cardiovascular risk in patients with that pre-existing cardiovascular disease. And the question that I get kind of all of the time is, what is that pre-existing cardiovascular disease? Like, what do patients need to have to perhaps be covered for semaglutide under this inclusion criteria? And so, what we have seen is that most of the time, insurance companies are looking and kind of replicating this inclusion criteria. And so the patient has to have established cardiovascular disease, and they would need one of the following. So they either need to have a prior MI, a prior stroke, or symptomatic peripheral arterial disease. And we will kind of get to this more in our second part of this webinar, a little bit more of kind of like what we've seen in practice. Um, but kind of broadly, what we see for these different indications is that um, a lot of insurance companies will say, we're not covering for weight management medications just as weight management medications, but then we will see that they're covering for some of these other indications, such as this one up on the screen. And so one example is Medicare. We've seen that Medicare kind of has this blanket statement against obesity medications, but many Part D Medicare plans do cover for this indication. And so it's important that we know kind of like the details of getting in this inclusion criteria, one of these 3 bullet points essentially in this box here on the screen. All right, so we can go to the next slide now. And this is kind of the second indication that I want to cover, which is around sleep apnea. And this was the SURMOUNT OSA trial, so obstructive sleep apnea. And what it did is it enrolled people with pre-existing obstructive sleep apnea, with or without CPAPs, and obesity. And randomize them to receive maximum tolerated tirzepatide. And so that was to a goal of 10 or 15 milligrams weekly or placebo. And what they found here was that there was a reduced apnea-hypopnea index by about 50%, a little bit under 50%, but if we round, we could say 50%. So the apnea-hypopnea index is the number of apneas and hypopneas during an hour of sleep. And at baseline, participants in this trial had around 50 apnea-hypopnea index, so 50 events per hour. And the treatment reduced by, just under 50%, which is considered clinically relevant. And then also what they found in this trial was less sleep disturbance and improved sleep-related impairment. And so one thing that, can really resonate with my patients is just the thought that they will feel better during the day. A better night's sleep, feel better during the day. And then additionally, improved sleep apnea is really important because it helps overall health in many ways. So that includes, there's data around overall mental health, glucose management, and cardiovascular risk, among other, important clinically relevant improvements. Okay, so we have this indication around obstructive sleep apnea, and I want to look again at that inclusion criteria because when we think specifically about access to tirzepatide for the sleep apnea indication, we need to look at that inclusion criteria, and so that's on the next slide. And so they enrolled patients with previously diagnosed moderate to severe obstructive sleep apnea. And what they looked at here to demonstrate if it was moderate to severe is an apnea-hypopnea index of greater than or equal to 15. Okay, and so that's kind of that 15 is the cutoff that demonstrates that it's moderate, and then higher than that is severe. And it needed to be diagnosed with polysomnography, which is kind of like that overnight test, which measures the apnea-hypopnea index. And Abby's going to talk next a little bit more about like what we've seen in practice as far as kind of what different groups are covering for this and what they're looking for more specifically. Um, and so this is what we've seen, that this apnea hypopnea index is really kind of a key point to that people are looking for because it was the inclusion criteria in this trial, which demonstrated improvements with tirzepatide. And so now we can go to one more current indication, which is our next slide. And I was excited to have the opportunity to change this just over the weekend. Late breaking news that on Friday, we had a approval for semaglutide for metabolic associated steatohepatitis. And so this was as a result of the Essence 3 trial, which, the high level is demonstrated here. And so the Essence 3 trial enrolled patients with steatohepatitis and liver fibrosis, stage 2 or 3. And again, randomized patients to semaglutide or placebo, and found that patients taking semaglutide, 62.9% of patients had resolution of steatohepatitis, which was 28.7 percentage points larger than the placebo group. And um, and so here, when we think about the patient population, they said that it was biopsy defined metabolic associated steatohepatitis or MASH and fibrosis stage 2 or 3. And so what they were doing in this trial is taking liver biopsies and visualizing those and looking for certain data. And I'll talk
I
about
am
that
an
more.
ambulatory care clinical pharmacist calling from Riverside Health. I was the one that
And so they're looking at this data, and we can go ahead to the next slide. So here is just a little bit more information on this for those of you who kind of want to see this more visually. The box A on the left shows the resolution of steatohepatitis, and you can see the difference between semaglutide and placebo with that estimated difference of 28.7 percentage points. And then group B shows reduction in liver fibrosis with no worsening of steatohepatitis. And again, there's a difference there of 14.4 percentage points. And what's kind of important about this trial, or what might be important to know and might also influence some access here, is that this is the first part of the trial. And so the first part of the trial looks at histological data. And the ongoing trial, which we should have results in a couple of years, is looking at clinical events. And so we'll, be able to know that soon, but the histological data is certainly promising. So we can go to the next slide, and I want to look at the inclusion criteria here. And so the question is, well, with this indication, with which patients with metabolic associated steatohepatitis might be eligible for coverage of semaglutide now? And what I think is really important here is when you look at that inclusion criteria, bullet point number 2 is histologically documented steatohepatitis and liver fibrosis of stage 2 or 3. And so this is a pathology reading of a liver biopsy. And so likely my hunch, although we're only 3 days into this approval, but my hunch is that, many people, when looking for coverage, many of the insurers are going to want that that is the gold standard, the liver biopsy in looking at steatohepatitis and liver fibrosis. There are some other ways that are used to look at this, but they are not as reliable as the liver biopsy. And so in addition to that pathology reading of the liver biopsy, there's also kind of a score that's determined by a pathologist as well. It's called the Non-Alcoholic Fatty Liver Disease Activity Score, which is this composite of steatosis, lobular inflammation, and hepatocyte ballooning, with each of those categories kind of having multiple different scores, and then you kind of take this composite score together. Some notes for this trial is that BMI was actually not an inclusion factor here for this trial. So the other two indications include overweight or obesity, and that was kind of a part of their inclusion criteria. Here, BMI was not an inclusion factor, although 72.8% of patients did have obesity. And then additionally, diabetes status was not an inclusion factor, but 55% of patients in the treatment group did have diabetes. And so when we think about, MASH, we know that we have some epidemiologic data which shows us how prevalent this is for patients. So there's MASLD, which is kind of this umbrella steatohepatitis, and that affects about 1 in 3 obese patients have MASLD. And then 20% of obese patients have fibrosis. And so this is also kind of a large population, I think, that will kind of be included here, but it's important to distinguish between the MASLD and then the MASH. And the MASH is kind of like including that fibrosis and more severe. And so I think that there will be some confusion. I can anticipate that among just kind of general fatty liver disease versus this more nuanced population that has that fibrosis as well, and the histologically documented steatohepatitis. Okay, so we can go on to the next slide. Just a little bit more about MASH while we're talking about it. So that previous trial was with semaglutide, and semaglutide now has that approval. Tirzepatide has a phase 2 trial called the Synergy NASH trial, which had promising results, but there are no phase 3 trials that are announced right now. And then there's another medication that's not yet approved called survodutide, which is a GLP1 agonist and also a glucagon agonist, of which there's a phase 3 trial going on right now called the Liverage trial. So likely more data coming on that. And that's kind of like a segue into the next slide here, which is just a little bit more data about what we might expect in the future. And so, we've seen that these indications for cardiovascular disease, sleep apnea, and then this new one for MASH are likely going to and have increased access. And there are so many more studies, so many more trials out there that are really promising to kind of increase access farther. And so I just want to touch on a little bit of those and what we might see in the future. So we can go to the next slide. The first is around tirzepatide benefits in heart failure with preserved ejection fraction. And so this was a phase 3 trial called the Summit trial. And they enrolled patients with heart failure with preserved ejection fraction and also a BMI greater than or equal to 30. And what they found was that tirzepatide reduced the composite heart failure outcomes. And the finding was driven primarily by fewer heart failure events, not cardiovascular deaths. And kind of the sad note, I suppose, around access here is that their approval application was in, but the FDA asked for an additional study, and kind of with that ask, the manufacturers withdrew their application for the heart failure with preserved ejection fraction. So it's a little bit unclear here, how that, while we can for sure see clinically important results, when we're talking in this webinar specifically about access, I'm not sure how this might improve access, but we can keep our fingers crossed that that the data could be compelling enough to help with access for this specific population. Again, that would be patients with heart failure with preserved ejection fraction and also obesity. You can go to the next slide. So this is all about retatrutide. And as I was reviewing some of this data, I was kind of blown away by all of the trials going on here. A lot of phase 3 trials. And as a mother of an 8-year-old, I couldn't resist thinking that they were, collecting indications like Pokemon. And so retatrutide, it's not been approved yet. It's a subcutaneous once weekly GLP1, GIP, and glucagon agonist. And there are 3 phase 3 trials going on right now, each of which has the name Triumph in it. Triumph Outcomes is looking at patients with overweight or obesity and ASCVD or CKD. And the outcome is major adverse cardiovascular events and major adverse kidney events that they're looking at here. Triumph 4 is for patients with overweight or obesity and knee osteoarthritis, and they're looking at osteoarthritis pain, kind of on this like pain rating scale. And then the Triumph 7 is looking at patients again with overweight or obesity and chronic low back pain, and the outcome here is back pain. So a lot of kind of promising trials there, and we will need to see, what comes of those and what further indications we might see from those. So we can go on to the next slide, which is kind of the last one on emerging data that I included here because it does have a phase 3 trial. And this is around GLP1 agonists and dementia. And so the data that we have around this includes a systematic review showing that glucose lowering with GLP1 receptor agonists was associated with a significant reduction in all-cause dementia. And so out of that, we have the EVOKE and EVOKE Plus trials, which is using oral semaglutide and is currently studying the impact of that oral semaglutide on early Alzheimer's. They are in the inclusion criteria here, they're not looking at weight or BMI as part of inclusion, but rather just the Alzheimer's criteria or the early Alzheimer's designation. Okay, so we can go to the next slide. So I just want to talk about a summary of those indications that we just talked about. And so we have 3 FDA-approved indications. That reduction in 3-point MACE for people who are obese with cardiovascular disease, that's for semaglutide. Improvement in sleep apnea for people who are obese with obstructive sleep apnea, and that's tirzepatide. And increased resolution of MASH for people with steatohepatitis and liver fibrosis stage 2 or 3, and that's semaglutide. And as a reminder, looking at all those inclusion criteria, to think about, how we submit our prescriptions and how we help our patients gain access to these really important medications. And then we have the non-FDA approved indications. So these are different phase 3 trials that I shared. So we have improved outcomes in people with heart failure with preserved ejection fraction and obesity. And then phase 3 trials ongoing of retatrutide for people with obesity. And those are looking at many things: major adverse cardiovascular events, major adverse kidney events, knee osteoarthritis, and chronic low back pain. And then a phase 3 trial of semaglutide's impact on early Alzheimer's is underway. And so I would encourage you to review this data, use it. And Abby will talk a little bit more about, kind of like how we're working with this in clinical practice. And so what I'd like to do now is pass that on.
Thank you so much, Kylie. So hi, everyone. I'm Dr. Abby Lennon. I am a clinical pharmacy specialist at Inova. I practice in obesity medicine and bariatrics. And so I'm really here to talk about where do we go with all of this information. So as Kylie said, I think the future of managing patients with obesity really does center around all these additional indications that are coming out for these medications, but the day-to-day in clinical practice can be a little bit nuanced. So if you can go to the next slide, please. I have no financial relationships to disclose. You can go to the next slide. And my learning objectives, again, are really just to identify those key barriers, what is currently preventing us from getting these really important medications to our patients, and then try to develop some actionable strategies that maybe you can implement in your practice. And so we'll go to the next slide. So currently there are so many barriers that prevent patients from accessing these medications, and there's far more than what's even listed on this slide. But really starting with patients trying to identify appropriate providers. So patients with more complex obesity-related conditions might be referred to obesity medicine specialists or to endocrinologists to help manage. However, the wait times for these clinicians can be extremely long. And I found some data that back in 2023, which was the most recent data for this, there was only about 8,200 ABOM certified physicians. ABOM is the American Board of Obesity Medicine, and that number is for the United States and Canada together. So if we compare that to the nearly 50% of Americans that have overweight or obesity, we can see that there is this really large gap in the number of providers who are specialized in this area and those who are seeking care. And so this can put a lot of pressure on our providers in primary care to help provide some of these services for their patients who maybe can't get into one of these specialists. But primary care maybe is not always well equipped to help manage some of these disease states, or they might not have enough staff or time to work through the authorization process. And so we'll talk about some strategies there to maybe help increase access. And there's also, once patients are taking these medications, there's also a lack of follow-up appointments or sick visit appointments if patients do develop side effects on these therapies. And so how are we going to help these patients if they are having some difficulties when they get started? So we really want to make sure that not only do we just get patients started on treatment, but that we are following up appropriately and making sure that we're really optimizing that. Oftentimes, in what we see a lot in our clinic, this leads to many phone calls, many patient messages in the EHR. And so it puts a lot of burden on our front staff who are trying to triage some of these messages back to our providers. And that can be for a number of things, not only prior authorization status, but also about side effects or getting a new prescription sent into the pharmacy. So those are a lot of the barriers that we deal with day to day, just in terms of getting someone started on these medications. Then, as I mentioned, there's, of course, access issues with prior authorizations. These can be really lengthy. They require a lot of chart review by our staff, and especially take a lot of time because oftentimes insurers want specific information about, excuse me, how long a patient has tried a specific medicine and what was the outcome with that type of medication. And so, that takes time to find when the patient was started, when was the medicine discontinued, why was it discontinued? And this is really where documentation can play a really key role in helping to make this process as smooth as possible for our staff. But oftentimes our staff too, who are doing these types of authorizations, they might not be extensively trained in pharmacotherapy or have any sort of pharmacy-related training. So it's also really important that we give them tools to help increase the success and help increase the access in terms of getting prior authorizations approved. And then finally, we're all aware that these are very expensive medications, and so there can be a lot of barriers. Even if patients do get an authorization approved, that doesn't always mean that it's going to be something that's affordable. And we saw this frequently in my clinic with our federal employee program, Blue Cross Blue Shield members. They have access to the medications, their prior authorizations get approved, but these medicines were moved into Tier 3 in 2025, and the copays have been extremely high and often unattainable for a lot of our patients. We can go to the next slide. And so we do have this change in perspective where we are moving from just managing weight as its own condition into trying to manage all of these cardiometabolic conditions, because we know that they do interplay very frequently. And we also know that these newer medicines now have benefits in some of these other conditions, as Kylie taught us. And so we really do need to start increasing the number of providers who are willing to prescribe some of these products. It's going to be really important that we try to engage some of the other specialists to look at these new indications and start to feel comfortable in helping to prescribe these medications. So, for example, here at Inova, we've been trying to encourage our cardiologists to prescribe for cardiovascular risk reduction in those patients who have had previous MIs, strokes, or PAD, or trying to engage neurology and pulmonology to help prescribe for patients with moderate to severe sleep apnea. And this is kind of a nuance here in Virginia, but we've actually seen our state Medicaid program is requiring that these prescriptions come from these specialists. For example, our Medicaid program will cover Wegovy for cardiovascular risk reduction, but the prescription has to come from cardiology. So we are even running into these barriers in our clinic and needing to partner with some of our cardiology cohorts here so that we can increase that access. So that's one very small example. I don't think that's very typical, but that's something that we can run into. As pharmacists, we can really help provide this education, not only in terms of trying to identify the right patient for these medications, but we can also help educate our providers in terms of being more comfortable with the complex titration schedules. We can also create, patient education that can help with some of those conversations when patients are getting started on medication. So for example, we have, a quick handout about eating on GLP1 type medications, and we can walk through that with our patient, which just provides some of those common strategies like avoiding greasy, fatty foods or eating smaller, more frequent meals throughout the day. All right, we can go to the next slide. And so if pharmacists are embedded directly within the clinic, then that obviously opens things up a lot as well. If pharmacists have a collaborative practice agreement, then, we can help prescribe or adjust the dose of these types of medications. We can also help our prescribers switch between products when these shortages or products go on back order, which does happen very frequently with these types of medications. We're often one of the most accessible healthcare professionals, so we also can help provide some of those follow-up appointments and help identify and treat side effects early as they come up. And this also is a really important place where we can engage some of our community pharmacist partners, because they are often seeing folks in the OTC aisles looking for products to help with constipation or diarrhea, and so they can also play a really important role here. We can also discuss lifestyle recommendations, check on adherence to those recommendations, and also help with cost-saving opportunities, which I'll go over more at the end. And so one question I get very frequently is, what does my day-to-day look like in my clinic? And so I mentioned that we had a huge volume of patient messages coming in our electronic health record. We also get an incredible number of phone calls, and our providers have very few follow-up appointments. And so we took all this information and really thought, how can we help access? And so it was decided that I would come in and help with patients who were getting started on incretin-based medications. And so what you can see here is the patient would come in for their initial consult with one of our providers. I work with both physicians and nurse practitioners. And if an incretin-based product was prescribed, then they would move, that patient would then need a prior authorization. So that gets sent to our team to get started on that. And then once that is approved, that team will help schedule 3 appointments with me. Ideally, I am trying to see patients right around that time of dose adjustment. And as we're commonly using just weekly products now, that's typically happening around week 3 to 4 of therapy. So once the patient has been started on the medicine, I follow up with them around their 3rd to 4th injection of that product. And I will show you an example of kind of what we talked through during the visit. But then I follow up with them on a monthly basis for a total of 3 appointments. Again, ideally right around the time that we are making those decisions about titrating the therapy. And then in their 4th month, they go back to following up with either the physician or the nurse practitioner. This has done a few things. It has cut way back on requests for new prescriptions because I am able to prescribe their next dose in the titration series during these appointments. It also helps ensure any cost issues. So I can help make sure patients get coupons, or if there's still prior authorization issues that need to work out, we can do that. And it also has cut way back on patients emailing or messaging about side effect management because they know they're going to have this visit unless it's really severe. Most of our patients are kind of waiting for this appointment to talk through some of that side effect management. And I also like to provide patients with kind of future strategies if they might not be having them now, but for example, how do we manage constipation if that's something that comes up in the future? And then of course, throughout this process, we're also referring our patients to the dietitian, exercise physiologist, or behavioral health partners as appropriate. And so we also have had increased appointments for some of those other visits as well. And I'm very thankful I have access to all of these different specialists, but I recognize that might not be in your clinic. So we can go to the next slide. So this is an example of what I go through in the visit. We do schedule 30-minute appointments with me, and I find most of the time I don't need that, but it allows time for documentation or follow-up with the pharmacy or anyone that I need to talk to. And so just a quick overview, again, I'm confirming the current dose that the patient's taking, review benefits of the medicine. Is it helping? Are patients noticing weight loss or reduction in hunger and appetite? We talk through any side effects. I check in on those lifestyle recommendations. So are they implementing a high protein diet? Have they been able to exercise? Are there barriers there that I can help with? And then, of course, perform a medication reconciliation and then help prescribe the next dose. So whether that's continuing on in the dose titration or sticking with the same dose, maybe because they're having side effects. And we'll talk through that process. And it is a very shared clinical decision that I make with the patient. And then, as I mentioned, I help provide some of those mitigation strategies. So similar to what we do with patients with diabetes in terms of providing them education on maybe how to manage a low blood sugar. They might not be having it right now, but we need to give them those tools in terms of how to manage that if it does happen in the future. And so that is something that I go through with my patients. You know, you might not be having constipation now, but this is our recommendation if you do experience that. And then I will also confirm those follow-up appointments both with myself and with other providers in our clinic. Anything that falls outside of my scope of practice will either get communicated face-to-face with a provider here in clinic, or I'm able to send a message to help follow up. And oftentimes this is if patients need like anti-nausea medication prescribed or something like that. All right, next slide. So just a real quick touch. So we do find it very important and very impactful to set expectations with our patients, and this can mean a few different things. It's really important that patients understand the barriers that we do face with the insurance company. And I think because so many of my patients are on social media and seeing these new and exciting indications come out, there can be some misinformation between what they see online and what is actually happening. And so a great example of this is when Zepbound was approved for management of sleep apnea. We had a huge request from patients that they wanted to seek insurance approval for that. And that's really great, but we do need the sleep study, and we do need to confirm that the patients have been diagnosed with moderate to severe sleep apnea, again, as Kylie mentioned, using that apnea-hypopnea index. And so just letting patients know that there is some nuance around this, and we can, you know, advise them in these appointments if we think that they would be meeting those restrictions or not. And then finally, just another note here, we also do set expectations around how long the prior authorization process can be, just to help cut back on some of those messages. So we typically tell our patients it can take 7 to 10 business days in order to hear back from us about the status of their prior authorization. And please try not to contact us during that time unless there is some urgent need. And then if they haven't heard from us in 10 business days, they're welcome to contact us to check in. And this is my final slide. Sorry, we can move on to the next one. So again, there are a lot of barriers in terms of cost and insurance. It is really important that we train our staff accordingly for prior authorizations. And my best advice here is to know who your payers are in your area. So we deal very often with our federal employee program, TRICARE, and Virginia Medicaid. And so it's important that we know what they are looking for in terms of criteria for approval, and then we can help train our staff on how to identify that criteria in the patient chart. I've helped make cheat sheets for our staff in terms of like the quantity of each medication and the day supply. Little things like that can really go a long way. And then, as we're able to help patients with cost, there are manufacturer coupons. Some patients will get a mail order discount if it's sent to mail order. And then we do have out-of-pocket programs, which do reduce the cost a little bit, but it's unfortunately still very expensive. Each medicine, both Zepbound and Wegovy, is about $499 per month if you do the direct from the manufacturer program. And so still very expensive, still not attainable for most patients, but it has helped increase access a little bit. And with that, I am actually going to turn it over to Shannon, who is going to touch on this a little bit more.
Hey, thanks so much, Abby, and thanks everybody for your engagement today and wanting to learn more about how to expand these agents in terms of expand access for these agents. I'm going to end with a discussion on compounded drug therapy and specifically in regards to safety, individualized dosing, and the law right now. With incretin-based therapy, I have no financial relationships to disclose. And we're going to talk about, in particularly, optimizing and managing and monitoring when patients are on compounded therapy. You may think that since the agents are no longer on the shortage list, that this may never come up. However, there are I had a patient last week who came in for another indication, and she let me know that she was receiving compounded product from an online telemedicine supplier. And so I think that it still is very much an important conversation, particularly with regards to safety and how we navigate the legal considerations when we find a patient that may be on compounded therapy. So I want to ask you to imagine that you are in a clinic, that you're seeing patients for obesity, and you have a woman who brought in a semaglutide label ambered vial without a pharmacy name on it, without a concentration on it, and she was asking you for a syringe and how much should she inject because she was unable to get her Ozempic from her pharmacy. I also want you to imagine a patient who comes in, particularly a woman who pulls out literally a Dixie cup out of her purse and shows you some powder in that cup and asks if you could help her figure out how to make that a liquid so that she could inject that as well. Finally, I want you to imagine what you would do. Would you know how to send a prescription to a Canadian pharmacy for patients to obtain international formulations in a time of drug shortage? And literally all 3 of these patients brought in or these requests to someone in our clinic during the time of the shortage. And this was a level of desperation that I had never seen before with any other medicine class. And at this point, I had been practicing for almost 25 years. And I think we all understand that access, when it's limited, there is a disappointment would be not a strong enough word. But when desperation ensued, and you can go to the next slide, I went to our medical team, and this was early in 2022, and we were seeing patients purchase things, unverified sources of medicine that could not be verified online, and patient safety was a huge goal of mine. I went to our medical team and we talked about the pros and cons of using compounded formulations during this time of drug shortage. And our medicine team, while our medical director was concerned in the beginning for efficacy and safety, his vantage point was, if my pharmacy team believes that we can do this in a controlled manner, then my patients are safer. Our patients are safer within a pharmacist managed situation instead of purchasing unverified sources offline or online. And I am the lead author on this paper, and I want to share with you that never in a million years had we gone to recommending compounded medication first. That is not the discussion today. The discussion today is how we as clinical pharmacists get involved when patients are either in a situation where there is a drug shortage or when there's limited access, and what are the legal and safety ramifications. So this is our paper that was published in January of JACCP, and you can move on to the next slide. So this was a retrospective cohort that looked at the first 50 patients that we sent in prescriptions for compounded GLP-1s in the beginning of the shortage. These patients were obese, but they did not have diabetes. Some of these patients had prediabetes and metabolic syndrome. And the intervention was, when they could not obtain branded formulation, we would send in a prescription for compounded semaglutide or tirzepatide. We used a single pharmacy instead of allowing multiple pharmacies with various concentrations. We sent our prescriptions to a preferred state licensed compounded pharmacy, such that we could get a consistent product so that we could monitor efficacy and safety more tightly than we would had we allowed multiple pharmacies to be used. In this particular time frame, because we were concerned with both safety and efficacy, we were meeting with the patients weekly. And so, like Abby described her clinic, with every 3 to 4 weeks around the time of dosage titration, we met with our patients weekly because of the concern for safety and efficacy. We were monitoring for weight. We were looking for early opportunities to intervene on safety when adverse events may be occurring. We were able, like Abby described, to talk about caloric restriction and how the patient should be exercising, and what water requirements and what protein requirements were they meeting on a weekly basis. And this also allowed us uniquely to be involved in individualized dose titration. We were able to limit titration when side effects were of concern, and then perhaps advanced titration. And we were very similar to how the clinical trials with branded products advanced titration, but we had a little more flexibility because of the individualized dosing. We drew labs at baseline in 12 and 24 weeks, and our primary outcome was changes in weight and BMI and A1C from a safety perspective. All of our secondary outcomes were related to cardiometabolic risk, and we looked at waist circumference, blood pressure, triglycerides. We did look at inflammatory markers, adherence, and adverse drug events. So what we found, and again, this paper was our first 50 patients. There were 18 males and 32 females. 50 patients completed the first 12 weeks, and 40 of those patients went on to complete to 24 weeks, and all of those 40 patients went beyond 24 weeks. Of those 10 that dropped out between 12 and 24 weeks, 3 were due to cost, and although the cost of the compounded formulation was less than paying out of pocket for branded formulation, cost was still an issue for some patients. 2 were discontinued because of safety concerns and and I'll talk about that a little bit more in a moment. 2 were lost to follow-up, and 3 met their weight loss goal and dropped out because they were at their goal. As far as primary outcomes were concerned, we saw a 7% weight loss at 12 weeks, which was statistically significant, and a weight loss at 24 weeks of 11%. When you look at the STEP trials, this is very much in line with semaglutide. There was a 6% weight loss at week 12 and 11 by week 24. So we felt that this was very much establishing that there was efficacy with this compounded product. Our BMI went from a baseline of 34.6 to 30 at 24 weeks. It was 32 at 12 weeks. Each time point, 12 and 24, were statistically significantly different. And our A1C went from a baseline of 5.5 to 5.3 at 12 weeks and 5.2 at 24 weeks. Again, statistically significant. All of the cardiometabolic risk factors that we were following improved significantly at 12 and 24 weeks. And what was really eye-opening to me was that because, this was a time of drug shortage, we were able to use off-label medications for patients with prediabetes and metabolic syndrome. We went from 19 patients at baseline who had prediabetes to 1 at 24 weeks. And this was statistically significant, but that represents a reduction in 90%. Metabolic syndrome, we had 24 patients at baseline and 5 at 24 weeks. So prediabetes and metabolic syndrome, to me, represented an opportunity for early intervention. We had 2 patients who were escalated to physician care. We brought these to the physician, and one patient had severe heartburn. They could not even tolerate the beginning dose of semaglutide, so they intractable nausea, vomiting for the 0.25 milligram dose. And the second patient had possible cholelithiasis. When the physician looked at the patient, however, they had tolerated semaglutide for 19 weeks prior to this possible gallstone issue, and they had also been started on a new medicine within 7 days of this presentation. And that's discussed more in the paper, but it was not deemed that the adverse event was due to the compounded product by the physician, but the patient stopped therapy nonetheless. And our average dosing for the injectable compounded product was less than, and almost 50% less than what was used in clinical trials. And I can answer questions about individualized dosing, but all I will say is that we were able to achieve similar weight loss with less medication. So the main things from this experience, and I realize we may never be in a situation where there's a national drug shortage of both agents again, but what we learned from this, I think, is still applicable because of the access issue. And that is when access to these agents is diminished, desperation can ensue, and patients will place the promise of efficacy of some substance that they may buy on the internet over risk to themselves. And that concerns me greatly as a clinical pharmacist. As I said before, those patients who may not meet obesity or diabetes, and now the extended indications, there are still patients who represent a population for early intervention within that cardiometabolic space that derived benefit from a compounded formulation. And compounded formulations allowed us to use off-label and allowed us during that time to individualize dosing. Clinically, what we learned, and I say this with caveats, and that is that during that time frame, using compounded injectable was deemed safe and effective, but we had very strict monitoring policies involved. We were using a single pharmacy, which allowed us a single formulation, a consistent concentration that mitigated a lot of dosing errors and adverse drug events, we believe. And weekly visits with us in our cardiometabolic clinic provided personalized recommendations, and it also held that patient accountable to lifestyle modifications that are necessary with these drugs. And overall, we only had 2 patients who needed to discontinue therapy because of safety. And this was a lower dropout rate than what was seen in clinical trials. So where are we in 2025 with the current state of compounding for incretin-based therapies? And I want to start on the right, and that is everyone is aware that these agents are no longer on the FDA shortage list, so they can no longer be legally mass-produced by compounding pharmacies. There are caveats, however, where individualized therapies are legal, and I'm going to go through that, but we live in a wild time. This is regulated by state boards of pharmacy. Many state boards of pharmacy have come down on compounding pharmacies and have stopped altogether any compounding of injectable. But there are still situations where it is legal to compound a medication. Lilly has filed multiple lawsuits against compounding pharmacies and telehealth providers. And as with any lawsuit, though, this is not going to be solved overnight. And so you still may come into contact with a patient who is working with a telehealth provider who is using a compounded product. So I think some of these best practices will apply to you if you come across a patient who is receiving these therapies. So compounding has always been allowed for individual patient need with valid prescriptions. And I'll give you a couple of examples. So, for example, like with alpha-gal, where patients are allergic to any mammalian product. Many of these patients have allergies to gelatin capsules. And so this is a natural compounding, a legal compounding example of how patients can, or how compounding pharmacists can compound an FDA-approved medication in a different formulation for patients. There are also situations where patients can't absorb or patients can't swallow pills, where alternative dosage forms can be legally compounded. There are unique dosage requirements in some individuals who may have intolerability, where a compounding pharmacist can compound a particular dosage requirement met for an individual patient need. There are examples where medications can be combined that are a rationale for compounding a combination therapy. And compounding is legal when an FDA-approved commercial product is not available, as was during the drug shortage not too long ago. So when you think, I'd love to say that my goal during going through the legal requirements is just to give you some comfort level that compounding should not be a bad word. It should be used in situations where commercial products are not meeting the needs for our patients. And I would like to remind everyone that compounding pharmacists are our colleagues, and they have or should have our patient's best interest at heart. And so compounding pharmacies, although an injectable or a compounded medication is not FDA approved and not studied or followed by the FDA, the pharmacy actually is. And the pharmacy should be an accredited pharmacy, and compounding pharmacies actually have stricter requirements than our community pharmacies do. And all of this is under Section 503A of the FDC Act, and I've provided for you the link below so that you can go deeper into this if you desire. All compounders, though, are not equal, and I think we all are concerned with bad players. And so in terms of a best practice, I would suggest that you look for facility. Is the pharmacy accredited, and are the compounding pharmacists within that pharmacy, do they have individual accreditations and licenses? Is that pharmacy within good standing by your state board of pharmacy? And that's always a very important question to ask. You can also ask, is that pharmacy in compliance with the Drug Quality and Safety Act? Are they following USP Law 795, 797, 800? And there are questions that you can ask from a provider's office standpoint to that pharmacist at the compounding pharmacy, where are you getting your active pharmaceutical ingredients? Your APIs should be coming from a FDA facility or a registered facility that provides USP grade product so that that medicine can be made with some reliability. You can also ask for what's called a certificate of analysis, and that will give you the percentage of how much of this is semaglutide, how much is this tirzepatide. You can ask for lot numbers, you can ask for chain of custody documentation, and you can ask for third-party testing. And all of this is done in an effort to ensure safety for that patient who may be receiving a compounded product. Unfortunately, because access still relies a lot on the cost of these agents, particularly as Abby mentioned, if you're using direct pay, $4.99 is still unattainable for some of our patients. And compounded product was cheaper than direct pay options, but it is not okay legally to send a prescription for a compounded formulation based on cost alone. But you can compound for other reasons, and you can move on to the next slide. This is under Section 503A of the Food, Drug, and Cosmetic Act, and it is okay to compound a formulation of an FDA-approved product for individual patient need if the drug is not essentially a copy. And so that means it has to differ from the commercially available product, either by dosage form. So, for example, there are troches and sublingual forms of GLP1s. Strength, it cannot be the same as a strength that is commercially available, and excipient. And so many of the online pharmacies or the telehealth providers are still using excipient changes so that it is not essentially a copy. So, for example, a B vitamin or an amino acid is added to that injectable such that it no longer is truly just semaglutide or just tirzepatide. It cannot be a repackaged version of a commercially available drug unless it is on the FDA shortage list. And the FDA shortage list law comes under the section of 506E of the FDC Act. It can be made from an FDA-approved drug into a different dosage or a different dosage form if there's documentation for clinical need, and that must be on the prescription to the compounding pharmacy. So, for example, of the 2 patients that had to discontinue our program because of intolerability, the one who had severe heartburn, was able to tolerate a troche that was made into a much lower dose than that starting dose of the injectable. And this is a legal alternative for this patient to receive GLP-1 therapy. Also, compounded product is not considered essentially a copy if, and this needs to be, several of these need to be met. It has to be tailored to a specific patient's unique needs, so it really individualized therapy. No FDA-approved version exists in that same form, strength, or route of administration. Thirdly, there needs to be a documented medical rationale. So the patient on the prescription, and this patient has an inability to swallow pills. This patient has an intolerability to the starting dose of 0.25 semaglutide, or there is an allergy involved and you're avoiding an excipient. And finally, it's expected to produce a significant difference for the patient. And there's a lot of nuance in that. There's not a lot of cases in the literature for when law is concerned. I imagine that as these lawsuits roll on with Lilly against some of these compounding pharmacies, that the FDA may change, or this law may change, indicating some requirement for significant difference, but this is currently on the side of the provider. You just anticipate that this will make a significant difference for the patient. So to summarize best practices, and I mentioned several, if a compounded agent is to be used, it really should not be used when an FDA-approved product is available. However, if you are encountering a patient who is receiving a compounded agent, or your practice may consider sending a compounded prescription in based on individual need, you need to have due diligence when picking a partner. This needs to be a state licensed, accredited pharmacy. They need to obtain sources from FDA approved facilities. You need to ask questions about certificate of analysis. This is highly important for patient safety. We at our clinic, in the beginning of the drug shortage, because we were very uncomfortable in the beginning with utilizing compounded product, we required a patient consent form. And that included a lengthy discussion of potential risks and benefits and a requirement for that patient to follow up so that we can ensure for safety and efficacy. And lastly, I think a best practice should be that when you do encounter an adverse event, particularly with a non-FDA approved product, that must be reported to MedWatch. The med spas and online clinics, I'm not sure if they're trained in adverse event reporting, but the only way the FDA knows is if we take ownership in this piece. So I'm not usually a Debbie Downer. I will just say that I am excited about the expanded indications that Kylie went through, but I also am a realist and understand that many of our patients are impacted by insurance and insurance changes. We experienced on July the 1st of this year that CVS Caremark basically excluded all Zepbound prescriptions for obesity. We had numerous calls that month. That was a very busy month trying to figure out how our patients were going to continue their therapy, and that affected nationally almost 30 million patients. We know that TRICARE for Life at the end of this month is no longer going to be covering GLP1s at all for obesity indications. And in January of next year, Blue Cross Blue Shield of Massachusetts has announced that it will also exclude all GLP1s, whether or not you include a GIP with that for obesity. It'll only be covering for type 2 diabetes. So I don't think that, we are in a place where we've won yet, but you can advance to the next slide. We're going to have to fight. And both Dr. Funk and Dr. Lennon have explained expanded indications, which Dr. Lennon mentioned that may require not only other diagnostic tests, but also involving other diagnosticians to initiate prior authorizations for these expanded indications. You can write letters, there are coverage exceptions, but all of this takes time and there is no guarantee. I really appreciated Dr. Lennon's advice to let the patient have some expectation. Just because we're appealing does not mean your insurance company is going to agree with us. The direct pay plans are, of course, a wonderful addition to gaining access for patients, but cost may still be a barrier. And if you read the fine print, there are restrictions with, Lilly has a restriction that you must refill your prescription every 45 days. And if you don't, if you show non-adherence, your ability to pay for direct pay may be revoked at any time without explanation. And finally, compounded products are not completely 100% out of the picture. There are situations where your patient may obtain a compounded prescription, but when you do so, it's our obligation to make sure that they are doing so legally and that we are monitoring for both efficacy and safety for better outcomes. And finally, I just want to thank everyone for your attention today. I believe on my soapbox that obesity should be treated as a chronic disease without these exclusionary policies or barriers that prevent good care. I know we are probably all in that same boat. We are soldiers. We are fighting right now, and access and improved access to these medications requires all boots on the ground. And I applaud you all for trying to meet the needs of your patients by using expanded indications and those direct pay options. And if a compounded medication is used finally, ensure best practices under the legal requirements, use dosing individualization, and make sure that you're that there's a reason for such, and monitor strictly for efficacy and safety. And we are going to switch over and take questions now, if I am not mistaken.
Excellent. Thank you all so much. We are definitely so lucky to have all three of you all speak on this topic, as it is a growing area of practice in many different disciplines. I do believe that both Dr. Lennon and Dr. Funk were able to answer some of their questions through the chat, I believe. And I think Yvette was okay with us holding off on taking other questions for now, since we are 12 minutes past the hour. But if there is any burning questions that someone wants to answer, or Dr. Finks, if you want to answer maybe some of the compounding questions, I'm okay with that as well. I just didn't want to hold you past your time.
Yeah, the only question I think that wasn't mentioned in the presentation was, where are the compounders getting their product? If they're on the national shortage list, where are these compounding pharmacies? And all great questions. There is no USP monograph, but I know for the oral compounded product, either in form of troche or in sublingual, which is currently what a couple of our patients are using because of intolerability to the injectable. They're using Rybelsus, which is a legal way to formulate a different formulation. And so that's 100% semaglutide in that case.
Excellent. Thank you all so much. Go
And
ahead.
that's right. That's right. I'm so sorry. One of the comments was that the shortages was due to the injectable devices, not necessarily the product in which the injectable was made from.
Excellent. Well, Dr. Funk, Dr. Lennon, Dr. Finks, thank you all so much. We greatly appreciate your expertise and knowledge that you have brought us today. Thank you, everyone, for joining. Have a great rest of your day.